Well, hi everybody. My name is Garrett Schmidt. I'm CEO and managing editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Roji Health Intelligence. Today's session is part two of a two-part series called Best Value-Based Care Strategies or for a cost-focused future. And today's session is called Controlling Specialty Care Patient Costs. A few items of note before we get started. Uh, all attendees have joined today in listen-only mode, so this is kind of a traditional webinar format, so we can't see you or hear you, so don't worry about turning off your mics or your camera or anything. Also, we do want to hear from you, though. We're going to have a time for some Q&A towards the end of the session, so if you have a question for either of our speakers, go ahead and drop that into your control module. There's a place specifically for questions, and we're going to get to as many of those as we can. We do have a big audience today, so if we don't get to yours for some reason, don't worry. Someone will make sure to reach out via email afterwards and answer your question. Finally, the session today is being recorded, so when we conclude, maybe about an hour or so afterwards, you're going to receive an email, and there will be a link to the recording as well as to the slides, and that way you can review it at your leisure and share it with colleagues and friends. And you probably will want to review this one because there's a lot here, and you're going to probably want to go back over it and really dive into it because it's kind of a deep dive. But excited to hear from our speakers today. With us, we have Miss Terry Hush, and she is the CEO and founder of Roji Health, as well as Dave Halpert, and he is the client chief of team. So, as usual, welcome Terry and Dave.
Thanks so much, Garrett. It's exciting to be back. We were kind of breathless at the end of last session, but we have lots to cover today, and I'll let Dave first introduce himself. And Dave and I will be tag teaming this morning like we did last week.
Thanks, Terry, and thank you, Garrett. My name's Dave Halpert. I'm the head of the client team here at Roji Health Intelligence. And about midway through the broadcast, I will be speaking about the difference between what we think of as a value-based care episode and then what you traditionally see in an episode-based care program, an official program, and how you can align those two, and also how they diverge, and how you are going to be best poised to succeed.
That's right. We've got a lot of technical deep dive today. So first, I'd like to summarize a little bit what this slide looked like last week when we were discussing generally what was going on in value-based care. And we made a couple of prognostications that we think are coming to pass already. In fact, we'll be talking about that today. And that is definitely a big pivot towards cost control, a condensation, if you will, of a lot of the payment models into proven models and elimination of those that weren't performing to the extent that they should in cost. And then some of the open-ended questions about what's going to happen in the future in directions of specialty care. So we projected that there would be a lot more risk for participants involved and that we would start to see specialty negotiation as well. So we see a really big shift in the landscape. This looked like a devastation slide last week, and what we have now is trying to address the confusion in this golf game that's gone kind of amok. I want to spend some time this time talking about why should you trust us on this topic? Because I think it's key to understand where we fit in the technology sphere so that you understand where our authority on it comes from. First of all of our experience has been focused on healthcare costs. We've sat in just about every seat in healthcare, except for pharmaceuticals as a company. Our people experience is along the line of cost containment. We provide the technology to do that, and we have implemented that technology in all of our clients for the last several years. It's very clinically focused. We believe that the future comes from shifting the cost of care downwards, but in a way that is designed to maintain or improve quality. And so that's our entire focus about how we think the future should be in cost control. And the other thing is our technology, and what we believe is that in order to succeed in reducing the cost of care, you also have to have the tools to succeed under the payment models so that it's sustainable for you as providers. Now, before we head in, I really want to get a pulse of who we're talking to this time and whether you have actually approached specialty care costs before, and if so, in what context. So, Garrett, do you want to do the choices here?
Sure thing. So yeah, I'm going to pull this up in just a second, but I wanted you to see Terry spent some time picking these pictures to go with each of the answers. So, directing referrals based on claims or something else, asking PCPs to reduce, modify referrals, creating episodes for high cost areas, thinking and planning, or we are not convinced of the need to act yet. So I'm going to pull this up on your screen here, and you will see that momentarily. All right. And this is anonymous, by the way. So this is kind of just more for fun, and we're going to show the results here in a moment. And you might be thinking, oh, man, my goodness, we're doing a little bit of all these things. But if you had to rank in priority order, what's the number one
I think
answer for
most of
you?
these they're a little bit exclusive to each other. And by the way, that number one is a picture of a physician or a painting of a physician under the interpretation of Paul Klee.
Okay. So we've got, I think, most of our responses coming in. I'm going to give it about another 10 seconds. And again, this is anonymous. This is more just for fun. And we're going to show the results so you can see kind of where you stack among your colleagues and see what other people are prioritizing. All right, I'm going to shut it down in 5, 4, 3, 2, and 1. All right. So Terry, I know you're not able to see the results on
I,
your end, so I will read them out to you. So we have for directing referrals based on claims or something else is 13%. Asking PCPs to reduce modify referrals, 16%. Creating episodes for high cost areas, 22%. Thinking and planning, 44%. That seems to be the majority. And then we are not convinced of the need to act yet. We have 6%. So a little bit of all over the place.
so people are really thinking about what that tells me is that there is an understood need to deal with referrals, but some of you think that the way to reduce it is to reduce it. Others think the way to do it is to rationalize it. So that's one of the issues that I think I'd like to address in a lot of detail today, is what is the point of our activity to reduce costs and specialties? And let's start with this. Poster child, President James Garfield, who died of sepsis following surgery when and an antiseptic field was not common. And he was probed with bare fingers in the gunshot wound. So why should you care about managing specialty costs? Well, if you are going to grow patient care, you have to have value with that. So you need a reputation for value, and that gets into managing specialists with a very high value rep. For specialty practices, and really there's two audiences here. There's the ACO or health system type world, and there's the specialty group world too. And so both of you have different kinds of incentives in this, but collaborating for the best access to specialists is something that really helps everybody's, because we are going to need to optimize that supply of specialists to the essential cases. And we'll talk about why in a few minutes. 40 to 60% of the total cost of care is coming to specialists. Some numbers like 80% of medical decisions have been tossed around for directed by specialists. But the real issue is, how do we preserve the leading edge that the incredible boost in medical advancement in specialty care has happened, while we reduce the fragmented care, keep the control of costs, improve the decision process for the patient, and long-term consequences. And here's where you start to look at that. So when we look at spending by condition, we see a pretty solid picture of what people's mortality, mortal conditions really are as well, and a lot of comorbidity. So we see, some things are undefined, so we're not going to address that. We don't know why people are going for those conditions or what all the details are. But heart, the number one area, the highest volume over all the different conditions. Musculoskeletal, so we're looking at neurosurgery, we're looking at orthopedic surgery, infectious disease, and I suspect this is higher now than it was a few years ago because of COVID, nervous systems, sense organs, and so on. So going down the list, when you look at that, and here's a different way of looking at it without the detail, if you were going to address specialty care expenditures, you would want to start not with the things that aren't going to matter a lot to your cost profile, but looking at the major groups of conditions to be able to address in episodes or your various tools. Because you want to make sure that your efforts are going to count, that volume is going to be an impact on your bottom line. And I don't mean a negative impact by, it will be a positive impact if the way you are doing it is to control the expenditures, but you are expanding your reach through participating successfully in payment models that are directed towards an episodic payment. And the first up on that, which incorporates those volumes, is TEAM. We talked about TEAM a little bit last time. It covers 5 different classes of procedures, and it's going to be a key for cardiac. We see most of the large volume cardiac procedures moving into this payment model over time, or a similar kind of payment model, but CABG is up first. And then we see lower joint replacements, hip fracture reduction, femur fracture reduction, a spinal fusion, and then lower bowel procedures. Over time, we will see other high-volume orthopedic and cardiac procedures especially, but I think also conditions, moving into an episodic payment model. Specialty physicians. So there's a real myth out there that specialty physicians are driving a lot of unnecessary cost. And some of that may be true, but the reality of what we're trying to do right now is that the accountability for pushing cost is not the central issue. The more important issue is the appropriate use of scarce physician resources and improving the medical decision-making process so that patients are getting what they need to have and not what the incentives of the system currently allow, and then cost-effective care by the specialists themselves. So I don't think we need to play a blame game here, and that's part of the issue that we need to get over if we're looking for a system in which there's a collaboration between ACOs and outside or participating specialists or health systems and their specialists. Our referrals need to be based on a collaborative review of cost and driving costs in a cost-effective way. That is especially important because we have entered a period in which shortages of specialty physicians is at an all-time high. And those very procedures that are at the top of our list are reflected in these specialty numbers. So every line that you see here in red is a line that is under 90% in terms of access to care. So our charge really is to do two things. One is establish clinical referral criteria to ensure access for patients who need a specialist. And secondly, to select specialists based on the collaboration on costs, outcomes, and shared data. The common ground I see for that is both groups need to control and lower costs. Both need a better picture of where they stand relative to cost through data. What's hidden from the view of primaries or of specialists turns up in complications on the specialty side, turns up as higher cost to the ACOs. The payment models require a collaboration of those two groups in order to reach a really big volume on savings. Hospital and other facilities are dependent on use by specialists. Specialists require facilities to do their work. We have to be able to meet these groups in a common collaborative work timeframe, pairing up our expertise to look at costs and at payment models. There is a frequent employment relationship between the hospitals and the physicians. In fact, hospitals are the largest employer of specialty-based physicians, although with some groups, there is more of an equity-backed arrangement, employment arrangement. And I think that if you read what's come out from CMS today, you will see that there is a future negotiation of specialty rates under a global payment as pretty much a given. So how do you do it? And this is what we'll spend a lot of detail on today, is you have to have a mechanism to look at costs in a way that is going to provide the view of value and cost variation and what's needed or what opportunities you have for lowering the cost of care. And that vehicle is a value-based care episode. It requires sharing of data. It is best for agreement by the parties if that sharing of data is done through a neutral third party. In the same way that you can use a neutral third party like a data vendor to share claims data with your payers, so that the issues of competition between specialty groups or the issues between competition between groups at a payer level are neutralized. It's got to be a mechanism to do that. Specialists in particular are extremely competitive when you get them side to side. We've been there on that one, and we've been very careful to provide a view that is neutral for that specialist to be able to collaborate. There needs to be a consensus on the clinical pathway behind the care. So what does that mean? That means if you are arguing about the clinical outcome that you're looking for or the way of getting there, let's say between an open procedure and a closed procedure or a less invasive procedure, then you will never have a consensus on how you're going to reduce costs. So the clinicians themselves between the specialty and the primary organization that is under a global cap, let's say an ACO, will have to have a meeting of the minds of where the opportunities for costs lie and how far they can go to make that happen. There needs to be a joint development of cost and quality episodes. These can always be tweaked and customized by the organizations. There should never be like a common, this is the only way you do it, have kind of episode loop. There needs to be a feedback loop for specialists on results. If there isn't, it looks like a score, and it looks like the legitimate concerns of specialists on what happened in what case for what patient is not accounted for, and that doesn't work. An ACO in a hospital has an avenue for cost management as well, and we need to recognize that as a legitimate avenue that we want to improve during this process. And there's a big benefit if we can help specialists market their packages with greater ease. Many specialists want to market directly to employers. Many of them want to create packages directly for patients. And there's no reason we couldn't facilitate that as part of this process. So Dave, do you want to go into the details now?
Absolutely. So I'm going to talk about how to construct a specialty episode payment model and try to distinguish the difference between a value-based care episode, which will provide actionable analytics on cost, to what we see in coming out of CMMI right now, for example, where you're looking at more of an average, where you don't have the actionable data that you need to tell you how to improve. Now, with that said, by improving the individual cases, that will improve on the average, and you'll be able to succeed in episodic payment bundles of care like this or some other model. But let's talk about the bundles for a moment. Bundles of care do not equal episodes of care. So these are a couple of examples right out of BPCI Advanced, where they are looking at a bundle of cardiac procedures and a bundle of orthopedics procedures. And you can see there are 8 cardiac procedures, there are 6 orthopedic procedures. So being able to figure out how to get actionable data out of an overall cardiac procedure score is very challenging, especially when you're looking at something like a CABG, where the A and B costs come out to about $150,000, compared to a pacemaker, where the average A and B costs come out to a mere $2,000. So automatically, you're already starting out on wildly different playing fields. And so to be able to come up with an average for cardiac procedures is nice to have, but it's certainly not actionable. In addition to that, these episodic payment models have a standard performance period, and then they also have a standard time frame. And so those two don't always align. So if you're looking at, let's say, the enhancing oncology model, you've got a 6-month time frame for chemo following the initial treatment, but then also a 6-month payment period. And so those are never going to overlap. It'll give you a solid average of where you stand, but you don't really have the opportunity to see the trees. You just see the forest. It obscures the path to improvement.
So it's really kind of tricky because CMS calls these episodes, cardiac episodes.
Yes, they
And
do.
you just have to look behind to realize that they're a grouper, but they're not an episode.
It is a service line, definitely not a single episode. Going back to what I was describing before, how the episodes don't really fit into the performance period. So the way an episode is going to work, you've got your pre-trigger services, so in the few days before the trigger procedure, then you've got your post-trigger services, and at the end you've got your final cost. But when you've got an artificial block in there, like the end of a performance period, the tail end of those services are mathematically adjusted after the fact. It's just like in baseball, where if a pitcher allows 2 earned runs in 6 innings, the pitcher is going to have an ERA of 3, because you're going to look at the rest of the third of the game that pitcher would have pitched. This is the same sort of setup here, and so you're going to have some variations in your quote-unquote score versus your actual performance. And we've got an example of that here, where if a patient is, let's say, discharged early from a skilled nursing facility, that cost savings is not necessarily going to be reflected in your overall score. Um, it's it's your results are what are going to drive your insights. It's not an artificial window. With that said, the individual BPCI episodes are working. There's a standardization process that is going behind the scenes. It's also discussed in what CMS released this morning, that there is going to be a definite sort of standardization of quality measures. So of the 33 individual episodes plus the 2 population-based episodes in MIPS, 14 of those overlap with the 14 of the individual models in BPCI Advanced. So there is some sort of hard charge, as Terry had described earlier, to look at are going to be the high drivers of cost and standardize those within programs. So the next thing that we're going to talk about is how to weave some of these value-based care principles into model definitions so that you can create a value-based care episode that has all of the hallmarks of helping you improve in an episodic payment model where you're looked at on the average, but where you have the insights to get into the details and actually see where there is opportunity for improvement. And this is a flow chart that we have, and essentially the first thing to do is establish a goal, and it needs to be specific. It can't be something like we are going to lower our costs for whatever episode. There needs to be a very specific set of success criteria that follow that so that you can plan and implement how to carry out the steps that are going to be required. Next, did you succeed? And if you did, great, maybe. And if you didn't, well, that doesn't necessarily mean something is bad. If you didn't succeed, it could be that the goal was too optimistic. And in that case, you just need to sort of recalibrate what you are capable of affecting and try the process again. If you succeeded, perhaps that means that if the goal was too easy, that's not good either. You still need to go back and recalibrate to actually affect change. And then as we get towards the bottom, we start thinking about, well, first of all, is this goal maxed out? Can we keep doing it? And if the goal is maxed out, that's okay too. It just means that we have to continue to avoid backslides. And if you didn't succeed, that's not necessarily a bad thing. You have learned something. You have learned to you can look at the root causes and demonstrate fault from happenstance and learn from what you have picked up. It's not something where you have necessarily failed. It's that you have found another way to not make a light bulb. Eventually, that light bulb is going to be there.
I think this is your attempt to take that golf game on the first slide and shoehorn it into a flow chart, right?
I think so too.
I think one of the things that's been a big discovery for us in doing episodes for care for both procedures and high volume treatment and specialties is the extent to which you really do have to go back in continually and finesse your definitions of success. Oncology, in particular, has been fascinating in terms of, well, you can't establish really a pathway in terms of looking at cost in a vanilla way across all cancers and all stages of patients in cancer. It has to be, you have to look at groups of patients in a separate way. If they've been metastatic since the beginning, or if they are on the early end of that spectrum.
Definitely agree. All right, so let's talk about procedural episodes. They allow for medical innovation. The idea is to avoid costs down the road. After that initial procedure that sort of puts the patient in that episodic payment model, we are looking at how to keep them out of high utilization experiences down the road. Some of these procedures, there is a really big variation in cost due to both physician and patient factors. Those need to be examined, and your goal is to provide a mechanism so that you can look at the results and understand the meaning behind them. Again, going back to what Terry had described earlier, an environment of collaboration and not playing the blame game. So the timeline of a procedural episode is as follows. So you want to start by first looking at the timeline of a few days or up to a month or two before that trigger episode. Look at what happened prior to that procedure, because that is going to be a huge component in the procedure itself. So was the procedure elective, or was it an urgent procedure? If we're looking at a total knee replacement, obviously something that is elective is going to be attacked from a different angle than one that comes in from some sort of a trauma. During the trigger itself, the great questions to ask: where was it performed? Was it in a hospital? Was it in an ambulatory surgical setting? Sort of what surrounds that. And when you get it down deeper into the analysis too, you can start looking at are the anesthesiologists employed by the hospital where we did it? Are they a roaming group? Where's the variation there? There's all kinds of things that are going to come into that trigger procedure that are going to affect things downstream. And that's, where was the spending? Were they longer in a skilled nursing facility? Were they do they have other accrued costs? And after all that's done, we get to a point where the benchmarking is done, any standardization is done, and in an episodic care model from CMMI, they are scored, which we don't like, because that automatically means conflict. I'm better than you. He's better than this other person, and it just is not constructive, and it's not a collaborative environment. So for a key element of a procedural cost episode, what you need is clinical integrity, clear definitions, I cannot stress this enough, of service determination, so that you know what is actually included. Is it only things that are relevant to the procedure? Is it all costs? That needs to be understood up front. Ideally, they will include multiple sources of data, not just the claims data that you get from the administrator of the program. You would want, in a perfect world, and it can happen, a blend of EHR data as well. There's great clinical but non-billed data in there that can be essential in helping you sift through some of the results. Finally, quality and utilization findings, spotlighting on outcomes, and assessing external factors. Once again, I'm just gonna hammer this into the ground that this needs to be done in a collaborative environment, so that there is not that conflict that you get, because things are not going to improve if somebody feels like they're being scapegoated. This is a great example, and so you need to construct this episode so that you've got physician trust and buy-in. Without buy-in, you're sunk. And so to get that buy-in, you need to be able to provide the details. You can't just provide a here's how you did and here is how we are moving forward. No, if there is a challenge, if there is a question, you need to be able to drill down into this level of detail to figure out exactly what is behind the numbers. What is the episode window? What kind of services are there? Are there other comorbidities that patient is experiencing that may have affected costs down the line? And then also to ensure that you are correcting by procedure type. Was the procedure open? Was it arthroscopic? These are all things that need to be able to be accessed if the need arises, so that there is evidence to support your analytics thus far.
Yeah, I think that this is all a procedural view of what looks like on the financial side, but we're also capturing all of these other diagnoses, symptoms, even pulling symptoms from the EHR, all of this soft information that we can find to indicate the severity of the patient, what happens after the procedure, before the procedure.
Yes. All right. And that's what we want to talk about here is aggregating data to enhance patient profiles. The claims data that you receive from CMS is limited. It will tell you where the patient, it's useful. It will tell you where the patient went that is not within your four walls. But it does not include non-billed clinical data like labs, vitals, social history. So frequently we see undiagnosed obesity, which is obviously going to be a risk factor in something like a total knee, tobacco use that is not diagnosed, but it's obviously linked to poor outcomes following surgery, and then social determinants of health. So it helps you see risk factors that would otherwise go unnoticed and can illuminate your results.
And it can't be overstressed that we're looking at longitudinal data too. So all of this preliminary information about the patient doesn't necessarily come with the claim or the specialty procedure. It can be 3 or 4 years back that we're actually accessing this information.
Absolutely. So definitely one of the opportunities that you have here is to improve your data collection, and that will help you determine how to best intervene and improve costs over time following a procedure. You want to look at social determinants of health because connecting patients to community resources is going to be key to ensure that they get the services they need following that procedure. Improved diagnosis coding is going to be helpful because you are going to be able to recognize certain types of conditions if you were doing specialty condition episodes to prevent that disease from progressing. And it also will work out better on the administrative side for you because there is a huge difference in what is expected if, let's say, you have diagnosed something as uncomplicated. Let's say the patient is going in for a procedure and they have diabetes and it's just diagnosed as that E11.9, the uncomplicated diabetes. That patient is going to have an expected cost following the procedure that is much lower than what may be a more accurate diagnosis that includes things like renal issues or history of pressure ulcers or things along those lines. And then finally, if there are patients where they have emergency department and inpatient utilization and a behavioral health diagnosis and no behavioral health visits or referrals, they need to be able to be, and that again could be a limited specialty choice. We talked about that in our last show, is that of all of the specialties that have opted out of Medicare entirely, behavioral health is the primary one, but that doesn't mean that there aren't resources that you can connect these patients to. They should include outcome and quality measures. You need to look at the quality side of thing in addition to cost, because you don't want to assume that a higher cost episode is necessarily a bad episode. Acuity is a huge deal. As I described earlier, someone coming in with a trauma, or let's say a more advanced state of disease, let's say it's a removal of a tumor, someone with an advanced state of disease is going to have a higher cost than someone who is coming in earlier. It doesn't necessarily mean that anybody did anything wrong. It means that you need to look at it. And the kind of a parallel version of that is that in specialty condition episodes, if you're tracking a condition like cancer, lower cost doesn't necessarily mean better care. It could mean that the patient has not had as many touches, and it could also mean that the patient is on, there may be a drug that is higher cost that would result in better outcomes for the patient, but they're not on it. And that's obviously not a direction that you would like to go either. So, in terms of tracking these, you need to track both the episodic payment periods and value-based care episodes in parallel. You don't want to do the value-based care episode at the peril of of the one that you are actually participating in, but you need that value-based care episode to actually affect change. It's going to be the only way that you're going to get down to that level of detail that allows you to see some larger trends within that population that take you somewhere beyond the average. It's going to give you the ability to provide meaningful comparison between providers and educate them on outcomes of their colleagues without doing so in a confrontative way. And it's just, there's going to be more than you need than to just show those average costs and expect everybody to be on board. One of the things that we like to talk about here is the enhancing oncology model, which grew out of OCM, now is EOM. There are what we really like in here is that there are specific clinical episodes. There are 7 cancer types, and each one is looked at independently, so it's not bundled together. The impact of comorbid conditions that the patient has is recognized. Those are specifically flagged to ensure that those patients, first of all, are risk adjusted appropriately. Second of all, that they are continuing to, that the providers that are managing those conditions are also involved in the patient's treatment. You can't let someone's, let's say, diabetes go unmanaged while they're in chemotherapy, because you're going to see adverse effects down the line. There are some great quality metrics where data is provided for it, particularly related to end-of-life care. Things like hospitalization usage in the last 2 weeks of life, chemotherapy usage, and then the encouraging of hospice care. And this is all supported with claims data, which makes it much easier to interpret, provided you have somebody who can help you put it into a front-end format that you can see and utilize. Obviously, it's not particularly readable on its own, but the information that is within it is just amazing to be able to get your hands on. And that's where we go with how to capitalize. You need to be able to share understandable data with your clinicians. You cannot give them this spreadsheet of patients and say, these are yours and these are the high cost ones, and work on that. No, there needs to be a lot more to it to understand comprehensively the entire picture of the patient and what is going on. Again, the peer-to-peer comparisons, they can be de-identified, and there needs to be that method for physician feedback. Do not shy away from the questions. Questions mean engagement. In my former teaching days, if there was one thing that I knew that when I had a problem, it was no questions following a lesson. It means that there wasn't engagement. So you definitely want questions. You want engagement. You want people to understand what they're doing, why they're doing it, and how the results are being utilized. And that's where we can see here these de-identified provider comparisons. We're not trying to show anybody that they are a problem. Behind each of these is a story. Someone who has more patients and higher costs, there's 100 reasons that could be, but you're not going to know that as an organization until you recognize that there is a difference, and then you can figure out how to allocate your resources accordingly. Couple of final takeaways here for procedural and condition episode strategies. I'll say it again, the cost of care in a condition episode, it does not necessarily mean low cost is good, high cost is bad. That oncology example with the medications is a great one. Another one would be something like heart failure, where if a patient had been moved to the care of a cardiologist rather than a provider, there may be a much more enhanced pharmaceutical profile. That's good. That's good for the patient. So those high costs are going to prevent downstream effects. They are and should not be penalized. On a procedural episode, you want to be looking at variations in costs, seeing where they are and what you can do to bring everybody sort of in line, so that when you do enact a more global intervention, that it gets the maximum benefit, the maximum multiplier effect, because you have reduced the variations earlier.
Okay, so let's do a little wrap up on how you would actually implement these cost strategies without choking. And I'm going to go through very quickly, 5 different ways in each of these things. So 5 keys to implementing cost performance. What you need to do that. First of all, aggregated data that Dave referred to. You have to have claims data to do a real review of what's going on with your patient. Because if you don't have that claims data, you are not seeing all the services that are going into that patient. So it's a must to be able to negotiate that. And that'll be a topic on a future webinar that we do, is payer strategies for implementing cost. You will need technology to build episodes of care that are fitting for an overall view of your costs, finding the drivers of care, and so on. This does not exist everywhere in the market, and you will waste a lot of time if you try to build it. So we would suggest buying it, and yours truly would be happy to provide that. Specialty groups and areas to participate in your efforts. You'll obviously have to decide where to start and what groups are the most important in your arena to be able to do that with. If you're a specialty group, you'll be looking for an ACO or a health system that is interested in these kind of efforts to make sure that you have the data. Because if you're working with an ACO, the claims related to your patients should be coming to you as well. Collaboration, I won't go into that anymore, but that's the ground that we're arguing for. And you'll need a plan for every payer that's in your mix. Can't say that enough. 5 reasons why a learning approach is needed. Variation in costs is something that is going to happen. You will never have a situation in which variation in cost does not occur, and you can't brand that as careless. You have to also be able to see that there are trauma patients or other kind of patients in the mix for procedures, and other kinds of patients in treatment episodes under conditions that are going to be variable. Medication cost is a variation that you will see. Multifactorial, there are patient conditions and statuses, physician actions, environment, information. All of these are changing constantly. And part of your process is to dig out the influence of each of those in high or low cost. And we put low on that horizon as well. The goal is to investigate and understand, help fill the gaps in knowledge and processes, engage the clinicians, not scoring them, so that they can help lead you to a situation where costs are lower. And it must be supported by data sharing that does not shame. 5 ways to use comparisons in value-based care episodes. Really key. We see the clinical integrity of an episode of care in the value-based care arena to be an essential way that clinicians can be involved in looking at similar procedures and understand what is driving cost in different instances. Comparisons allow you to identify the absence or presence of services and interventions in the standard of care. If you see a history, this is not a specialty generally that we're going to find, we'll find this in primary care a lot. You see a long history of a patient with diabetes with no change in poorly controlled status and no change in the plan of care. No difference in medications, no dietary services, no referrals, a complete lack. It could be due to financial reasons or any other reasons. It could be due to the patient being not available or on autopilot. Could be due to the physician saying, this patient is just a lost cause for me. allows you to evaluate the effect of one factor, such as a diagnosis in behavioral health, on outcomes in patient episodes. You can match different conditions or different factors in your episodes to bring out the extent of the impact on cost or on outcomes. It allows you to screen for risk factors in patients to proactively manage them. So if you see a group of patients who are doing poorly, and you are seeing the exacerbations of the condition or utilization on the front end of that, then you can predict that those patients will be in a poorer status and likely have admissions or ER procedures. You can also see the existence of your low value procedures and start to go after that as a group. And you can convene physician groups to achieve consensus on care with high variability. They're powerful episodes for creating collaborative change as long as you keep your focus in a very clinically specific way. And here's one way that you could do it: Alzheimer's disease, an area where new things are coming out, new meds are coming out or have come out now, new blood tests are coming out, but yet you don't have a ripe arrangement or ripe collaboration occurring in most cases between primaries and specialists. Primaries feel somewhat uncomfortable with it. The blood tests, should they be used or not? But there's nobody at the other end, so no group that's available for you to refer all these cases. And neurology is one of those areas with a shortage. So your task there would be to create an episode population based on not just age, but several factors, perhaps the in-office screenings during a wellness exam, or some other factors that point from information from the patient support system that we've got a case worth considering. And then go through the processes with collaboration from the specialist consult, trading back and forth information throughout the time period. Start your journey with us. We are happy to share our experiences and consult with you on options in managing costs through episodes of care. As I said, we've done it. This is the thing that we are the most excited about in value-based care, and we think episodes are a really powerful tool to be able to do something in a positive way that affects both clinicians and patients. And now we have a few minutes for questions.
All right, we do have a few minutes for questions, and if you have a question that you haven't already asked, go ahead and use your control module that you have as an attendee and drop your question there. We don't have a whole lot of time, so if we don't get to yours, don't worry. Someone will reach out via email to make sure we answer your question. So go ahead and ask it if you got it. All right, in no particular order, this question is first. MA plans capture so much information under the HCC taxonomy. Are they inclined to cooperate with efforts of a health system to build these episodes?
Well, HCCs are all retrospective. They are giving you information about diagnoses that occurred, but they are not the same as having risk factors through an episode where you see things that are going to occur. And so I think that HCCs have never been powerful enough. If they were powerful enough, we would not be in the situation that we're in as far as escalating costs. So I see a real interest in collaboration. Not everybody, but I see that as we go further, specialists are very interested in having data. Certainly the specialty groups that we have are really engaged right now on the cost front. And so are our multi-specialty groups.
Great. Next question here is, Do you have a short list of initial steps or processes to take to move physicians away from fee-for-service thinking? As you know, not much of current specialty physician revenue is based on episodes or even adherence to care guidelines.
Well, there aren't a lot of payment models right now for specialists to participate in. The only ones out there that are still working is on the treatment side, the enhancing oncology model, which is it's been open for 2 periods, and then you have team coming up in selective geographic areas. I think that we're going to have a lot of specialty care models very soon, and they'll be coming out from CMS for sure. CMS will still, I think, be the leader in developing payment models for costs. They made it very clear they're going to be moving clinicians to risk, all of healthcare to risk, because
Just
they
this
see
very
it
morning.
as very morning. Yes. And you can talk about that, Dave, if you'd like to do that.
Oh, yeah, sure. CMS did just release CMMI, a new strategic direction white paper. And within that white paper, um, prominently featured are things like mandatory downside risk, the expansion of models, and expansion based on whether or not they save the U.S. taxpayer money. And that is absolutely going to be measured in terms of whether or not costs are controlled.
And specialists are under the same kind of incentives as every other provider. If you have an episodic payment, you want your costs to come under that so that you have a cushion. I think that specialists will be a lot more interested as things move to risk in participating in this kind of episode product, because it's the only way they can actually be sure that they're going to sustain under such a model.
All right, we have time for one more question. If it could be a quick answer, hopefully, I don't know. You tell me. The next question is this, how much of a role do you see for continuous patient vitals monitoring in VBC programs?
Continuous patient what, Garrett?
Continuous patient vitals monitoring.
Oh, well, I think that, I mean, we're seeing all sorts of technologies pop up for continuous patient monitoring. Uh, plus, yeah, I think there's going to be a huge demand under risk for moving care to be remote and more attached to patients and less driven by facilities and providers. And the physician shortage, which also occurs in primaries, a huge shortage in primaries, is going to also drive that too, the need for having monitoring. Will it be paid for? I think that that's an issue that will develop. If it needs to be paid for in some way, there will be some payment for it. So far, CMS has been very conservative on the payment of, let's say, the glucose monitoring. Have to have a diagnosis of diabetes in order to do that. So you're not capturing people who are going through a pre-diabetes situation. I see that changing over time because it makes sense to be able to capture people early if you can reduce the costs.
Gotcha. Unfortunately, we are out of time. We do have some more questions coming in, and if we didn't get to yours, again, someone will reach out via email afterwards to make sure we answer your question. Terry, Dave, thank you so much for a wonderful presentation yet again. We are going to be having another one coming up here in about another few weeks here, so stay tuned. We'll definitely reach out with that. And if you'd like to hear part one of today's session, we will send a link out in the little thank you email we send, and that way you can listen to that as well. But again, thank you, Dave. Thank you, Terry. That's a very in-depth topic. As we close out here, wanted to encourage you all to head over to vbcexhibithall.com and check out the virtual exhibit booth for Roji there. Terry, if I could have you go to that next slide,
Mm-hmm.
and you will see a little image of it there, and that's where you can do kind of a deeper dive on Roji and see what they're into, and there's a lot of great resources there, as well as at VBC Exhibit Hall. The library is where we will archive this webinar along with all of Roji's webinars that we've ever done with them, and there's a lot of other great resources as well. And again, thank you all so much for joining us. If you'd like to reach out to Dave or Terry or Leonard, who will point you in the right direction, their information is here. Or feel free to reach out to me too. I'm happy to facilitate an introduction if that is easier for you. Thank you all so much for spending your afternoon with us. Join us on the next one. And until then, have a great rest of your day. Bye-bye.
Thank you, everybody.
Thank you.